Hello, my name is Dana Leefers, and I am currently a PGY2 ambulatory care pharmacy resident. And today I will be talking to you about cardiovascular disease and risk management in patients with diabetes. ASCVD is the leading cause of morbidity and mortality for individuals with diabetes and is the largest contributor to the direct and indirect costs of diabetes. ASCVD is defined as acute coronary syndromes, a history of myocardial infarction, stable or unstable angina, coronary or other arterial revascularization, stroke, transient ischemic attack, or peripheral artery disease. The common conditions coexisting with type 2 diabetes include hypertension, dyslipidemia, and smoking, and are clear risk factors for ASCVD, and diabetes itself confers an independent risk for ASCVD. Numerous studies have shown the efficacy of controlling individual cardiovascular risk factors and preventing or slowing ASCVD in people with diabetes. In all patients with diabetes, cardiovascular risk factors should be assessed at least annually. A patient with diabetes should be screened for hypertension at every visit. Interestingly, in type 1 diabetes, hypertension is often the result of underlying diabetic kidney disease, while in type 2 diabetes, it usually coexists with other cardiometabolic risk factors. It is imperative that a proper blood pressure reading be recorded, in which the patient should be in a seated position, feet on the floor, and arm at heart level. Also, be mindful that a multitude of factors could affect blood pressure, including recent caffeine consumption, illness, stress, and use of other medications, especially over-the-counter Sudafed, and timing of blood pressure medications. Because of these factors, if the blood pressure is elevated, a separate reading should be taken on a separate day to confirm the diagnosis of hypertension. A great way of monitoring blood pressure is having the patient perform at-home readings throughout the day. Studies have shown that home measurements may actually correlate better with ASCVD risk. Randomized clinical trials have demonstrated the benefit of lowering blood pressure to less than 140 systolic and less than 90 diastolic in individuals with diabetes, including reduction of CHD events, stroke, and diabetic kidney disease. Individuals in whom cardiovascular disease risk, particularly stroke, is a concern may, as a part of shared decision-making, have lower systolic targets than 140. This is especially true if lower blood pressure can be achieved with few drugs and without side effects of therapy. For older adults, treating to a systolic blood pressure of less than 130 has not been shown to improve cardiovascular outcomes. Per the ADA guidelines, if a patient's blood pressure is greater than 140/90, lifestyle modifications and timely titration of pharmacotherapy should be initiated. If the blood pressure is greater than 169/100, lifestyle modifications and titration of two agents targeting blood pressure should be initiated. The pharmacotherapy agents include ACEs, ARBs, thiazides, and dihydropyridine calcium channel blockers. The ADA guidelines state that you can use any of these agents to achieve your blood pressure goal. Now, if the urinary albumin to creatinine ratio is greater than 300 or 30 to 299, the first-line therapy should be an ACE or an ARB to treat hypertension. Growing evidence suggests that there is an association between absence of nocturnal blood pressure dipping and the incidence of ASCVD among patients with diabetes. A randomized controlled trial of 448 participants with type 2 diabetes and hypertension demonstrated reduced cardiovascular events and mortality with a median follow-up of 5.4 years if at least one antihypertensive medication was given at bedtime. If patients are on multiple medications for hypertension, which most patients with diabetes will require multiple drug therapy to reach blood pressure treatment goals, consideration should be given to administering one of the antihypertensive medications at bedtime. Now, if blood pressure remains uncontrolled despite confirmed adherence to optimal doses of at least 3 antihypertensive agents of different classes, which one of those should be a diuretic, clinicians should consider an evaluation for secondary causes of hypertension. Patients with type 2 diabetes have an increased prevalence of lipid abnormalities, contributing to their high risk of ASCVD. A lipid panel should be obtained at the time of diagnosis if they are not already on a statin, and at least every 5 years. If a patient is initiated on a statin, a lipid panel should be obtained and periodically monitored to assess the patient's response and adherence. In all patients with diabetes, lifestyle modification should be emphasized, including weight loss if indicated, reduction of saturated fat, trans fat, and cholesterol intake, increased dietary omega-3 fatty acids and fiber, and increased physical activity. To learn more about these lifestyle modifications, you can listen to the third presentation in this diabetes series. When talking about the treatment of hyperlipidemia, there are multiple guidelines available, including the National Lipid Association, the 2013 ACC/AHA guidelines, the 2016 ACC Experts Consensus Decision Pathway on the Role of Non-Statin Therapies, and the USPSTF recommendations on statin therapy. The guideline that is followed is up to each individual practitioner, but for this presentation, we are specifically just focusing on the recommendations per the ADA guidelines, which say that all patients with clinical ASCVD should be on a high-intensity statin. In patients with diabetes less than 40 years with ASCVD risk factors, a moderate to high-intensity statin is indicated. In low-risk patients with diabetes aged 40 to 75 years, moderate intensity statin treatment should be considered in addition to lifestyle therapy. Clinical trials in high-risk patients with increased cardiovascular risk, such as an LDL greater than 100, high blood pressure, smoking, and a family history of premature ASCVD, have demonstrated that more aggressive therapy with high doses of statins led to a significant reduction in cardiovascular events. Therefore, high-intensity statins are recommended in all such patients. For adults with diabetes greater than 75 years of age, there's limited data regarding the benefits and risks of statin therapy, and statin therapy should be individualized based on risk profile. High-intensity statins, if well tolerated, are still appropriate and recommended for adults with ASCVD. High-intensity statin therapy may also be appropriate in adults with diabetes greater than 75 years of age with additional ASCVD risk factors. However, the risk-benefit profile should be routinely evaluated in this population, with downward titration performed as needed. This slide shows an overview of the recommendations for statin and combination treatment in people with diabetes. The high-intensity statin therapies include atorvastatin 40 to 80 milligrams and rosuvastatin 20 to 40 milligrams. The moderate intensity statins are shown on the slide, as well as the low-intensity statin therapy. Typically, high-intensity statins can reduce the LDL by approximately 50% or greater, and your moderate intensity statins can lower the LDL 30 to 50%, and low-intensity statins can lower the LDL by less than 30%. Each statin therapy has a slightly different pharmacokinetic profile. Atorvastatin is metabolized by CYP3A4 and has a half-life of 7 to 14 hours. And simvastatin has a half-life of 2 hours and is metabolized by CYP3A4. And these medications have multiple drug interactions. You can see pravastatin is not metabolized by CYP and has the fewest drug interactions. Also, rosuvastatin and pravastatin are the only two statins available that are not lipophilic. So these will cross the blood-brain barrier at a much lower rate than the other statins, which could potentially cause lower side effects than the other agents. Also important to note that with lovastatin, the max dose is 20 milligrams if used with diltiazem or 40 milligrams if used with amiodarone. Similarly, simvastatin has a max dose of 20 milligrams if used with amiodarone, amlodipine, or ranolazine, and 10 milligrams if used with verapamil or diltiazem. The ADA guidelines also provides recommendations regarding non-statin therapy. In patients that require additional CVD benefit with recent acute coronary syndrome or ACS and an LDL greater than 50 with a history of ASCVD and statin intolerance, ezetimibe and a moderate intensity statin is indicated. And this is based off the results from the IMPROVE-IT trial. The new medication class that is getting a lot of attention, the PCKS9 inhibitors, typically can reduce LDL levels by 36 to 59% and are recommended as an adjunctive therapy for patients at high risk for ASCVD events who require additional lowering of LDL or in patients who are intolerant of high-intensity statin therapy. Combination therapy with a statin and a fibrate is associated with an increased risk for abnormal transaminase levels, myositis, and rhabdomyolysis. The risk of rhabdomyolysis is more common with higher doses of statins and renal insufficiency and appears to be higher when statins are combined with gemfibrozole. Also, in the ACCORD study, in patients with type 2 diabetes who were at high risk for ASCVD, the combination of fenofibrate and simvastatin did not reduce the rate of fatal cardiovascular events, non-fatal MI, or non-fatal stroke as compared with simvastatin alone. Therefore, combination therapy is generally not recommended. But there is one caveat. Subgroup analysis of the ACCORD trial did suggest possible benefit for men with both a triglyceride level greater than 204 and an HDL less than 34. So in these patients, combination therapy with a statin and fibrate can be considered. Finally, combination therapy with a statin and niacin is not recommended given the lack of efficacy on major ASCVD outcomes and a possible increase in risk of ischemic stroke and side effects. Statins have a pretty bad reputation for side effects, with the most common side effect being myalgias. Now, several studies have reported an increased risk of incidence of diabetes with statin use, which may be limited to those with diabetes risk factors. However, although statins were linked to diabetes risk, the cardiovascular event rate reduction with statins far outweighs the risk of incidence of diabetes, even for patients at highest risk for diabetes. The absolute risk increase was small. Over 5 years of follow-up, 1.2 patients on placebo developed diabetes and 1.5% on rosuvastatin developed diabetes. A meta-analysis of 13 randomized statin trials with over 91,000 participants showed an odds ratio of 1.09 for new diagnosis of diabetes. So on average, treatment of 255 patients with statins for 4 years resulted in one additional case of diabetes, while simultaneously preventing 5.4 vascular events among those 255 patients. So the CVD benefits, again, far outweigh that risk. There's also controversy around statins being associated with a negative effect on cognition, but to date, published data cannot confirm this. Therefore, a concern that statins might cause cognitive dysfunction or dementia should not deter their use in individuals with diabetes at high risk for ASCVD. And again, if you think about the pharmacokinetic profile of your statins, if a patient is worried about having cognitive function decline, that can warrant use of a non-lipophilic agent such as your rosuvastatin or your pravastatin. And then just, of course, we do always want to avoid statins in pregnancy. In patients with a fasting triglyceride level greater than 500, the clinician should evaluate for secondary causes and consider medical therapy to reduce the risk of pancreatitis. To learn more about the treatment of hypertriglyceridemia, please refer to the Triglycerides and Cardiovascular Disease Statement from the American Heart Association. Aspirin has been shown to have positive benefits for secondary prevention in reducing cardiovascular morbidity and mortality in high-risk patients with previous MI or stroke. Therefore, clinicians should use aspirin as a secondary prevention in patients with diabetes and ASCVD. The dose of aspirin should be 75 to 162 milligrams. If a patient has an allergy to aspirin, clopidogrel may also be used instead. Now, for primary prevention, aspirin's net benefit among patients with no previous cardiovascular events is more controversial both for patients with diabetes and for patients without diabetes, and recommendations are not as clear. Previous randomized controlled trials of aspirin, specifically in patients with diabetes, failed to consistently show a significant reduction in overall ASCVD endpoints. The ATT collaborators published an individual patient-level meta-analysis of the 6 large trials of aspirin for primary prevention in the general population. These trials collectively enrolled over 95,000 participants, including almost 4,000 with diabetes. Overall, they found that aspirin reduced the risk of serious vascular events by 12% with a risk ratio of 0.88. The largest reduction was for non-fatal MI, with little effect on CHD death, with a risk ratio of 0.95, or total stroke. There was some evidence of a difference in aspirin effect by sex. Aspirin significantly reduced ASCVD events in men, but not in women. And then conversely, aspirin had no effect on stroke in men, but significantly reduced stroke in women. However, there was no difference of sex on the risk of serious vascular events. So in 2010, the ADA, AHA, and ACCC put out a statement and they recommended low-dose aspirin for primary prevention with sex-specific recommendations. However, since then, new data has came out showing that heart disease and stroke is equivalent, if not higher, in women. So per the 2017 ADA recommendations, clinicians should consider aspirin as primary prevention for men and women greater than 50 years with one additional major risk factor, such as family history of premature ASCVD, hypertension, hypolipidemia, smoking, or albuminuria if they have a low bleeding risk. Aspirin is not recommended for those at low risk of ASCVD, as the low benefit is likely to be outweighed by the risk of bleeding. Diabetic kidney disease, or CKD, attributed to diabetes, occurs in 20 to 40% of patients with diabetes and is the leading cause of end-stage renal disease. Diabetic kidney disease typically develops after a diabetes duration of 10 years or at least 5 years in type 1 diabetes, but may be present at the diagnosis of type 2 diabetes. Screening for albuminuria can be most easily performed by a urinary albumin to creatinine ratio, or UACR, in a random spot urine collection. Normal UACR is generally defined as less than 30, and increased urinary to albumin excretion is defined as greater than 30. UACR is a continuous measurement, and differences within the two normal and abnormal ranges are associated with renal and cardiovascular outcomes. Because of biological variability in urinary albumin excretion, 2 of 3 specimens of UACR collected within a 3 to 6 month period should be abnormal before considering a patient to have albuminuria. Exercise within 24 hours, infection, fever, congestive heart failure, marked hyperglycemia, menstruation, and marked hypertension may elevate UACR independently of kidney damage. For patients with diabetic kidney disease, the ADA guidelines suggest a dietary protein intake of 0.8 grams per kilogram per body weight per day. Compared with higher levels of dietary protein intake, 0.8 grams per kilogram showed slowed GFR decline with evidence of a greater effect over time. Higher levels of dietary protein intake have been associated with increased albuminuria, more rapid kidney function loss, and CVD mortality, and therefore should be avoided. Now, if the patient is on hemodialysis, this rule does not apply and they can have a higher dietary protein intake. Also, for patients with diabetic kidney disease, it is imperative for intensive glycemic control with the goal of achieving near normal glycemia, as it has been shown in large randomized studies to delay the onset and progression of albuminuria and reduced eGFR. For glycemia treatment, consideration can be given to SGLT2 inhibitors as they reduce renal tubular glucose reabsorption, intraglomerular pressure, and albuminuria, and slow GFR loss through mechanisms that appear independent of glycemia. Likewise, glucagon-like peptide 1 receptor agonist and DPP4 inhibitors also have direct effects on the kidney and have been reported to improve renal outcomes compared with placebo. Another important treatment goal for patients with kidney disease is a blood pressure level less than 140/90 to help reduce CVD mortality and slow CKD progression. In individuals with albuminuria who are at an increased risk of CKD progression, lower blood pressure targets such as less than 130/80 may be considered. ACE inhibitors or ARBs are the preferred first-line agent for blood pressure treatment among patients with diabetes, hypertension, EGFR less than 60, and UACR greater than 300 because of their proven benefits. I do want to point out that an ACE or an ARB is not recommended for primary prevention in patients with normal blood pressure, normal UACR, and normal EGFR. If a patient with diabetic kidney disease has an EGFR less than 30, clinicians can consider referring for evaluation for renal replacement. All patients should have yearly measurements of UACR, serum creatinine, and potassium. In patients with an EGFR of 45 to 60, referral to a nephrologist if possible for non-diabetic kidney disease if the duration of type 1 diabetes is less than 10 years, persistent albuminuria, abnormal findings on renal ultrasound, resistant hypertension, rapid fall in EGFR, or an active urinary sediment on urine microscopic examination. You also want to consider the need for dose adjustments of medications and monitor the EGFR at least every 6 months, as well as monitoring the electrolytes, bicarbonate, hemoglobin, calcium, phosphorus, and parathyroid hormone at least yearly. Assure that the vitamin D level is sufficient and vaccinate against hepatitis B. Consider bone density testing and referral for dietary counseling. If the EGFR falls between 30 and 44, it is important to monitor the EGFR every 3 months and again monitor for the electrolytes every 3 to 6 months, and always keep in mind the need for dose adjustment of medications. And then again, if the EGFR falls less than 30, clinicians should consider referring to a nephrologist. If a patient is on an ACE or an ARB, it still is recommended to continue the UACR monitoring to help assess the response and progression of the kidney disease. And again, early vaccination with the hepatitis B virus is indicated in those patients that are most likely to progress to end-stage renal disease. Patients with diabetes are at an increased risk for developing diabetic retinopathy. For both treatment and prevention, it is imperative to optimize both the blood glucose and blood pressure control. With patients with type 1 diabetes, an initial dilated eye exam should be performed within 5 years of diagnosis. And with patients with type 2 diabetes, an initial dilated eye exam should be performed at diagnosis. If negative for retinopathy and the blood glucose is controlled, exams can be performed every 2 years. If retinopathy is present, annual exams should be performed. Clinicians should promptly refer patients with any level of macular edema or retinopathy to an ophthalmologist who is knowledgeable and experienced. Laser photocoagulation can reduce risk of vision loss. Injections of antivascular endothelial growth factor are indicated for central involved diabetic macular edema. Diabetic neuropathies are the most prevalent chronic complications of diabetes. This group of conditions affects different parts of the nervous system and presents with diverse clinical manifestations. Diabetic neuropathy is a diagnosis of exclusion. Non-diabetic neuropathies may be present in patients with diabetes and may be treatable by specific measures. Up to 50% of diabetic peripheral neuropathies may be asymptomatic. If not recognized and if preventive foot care is not implemented, patients are at risk for injuries for their feet. Patients with prediabetes may also develop neuropathies that are similar to diabetic neuropathies. Recognition and treatment of autonomic neuropathy may improve symptoms and improve quality of life. Due to a lack of treatments that target the underlying nerve damage, prevention is a key component of diabetes care. There are a multitude of different classifications of diabetic neuropathies, which we will go over a few today. The first being distal symmetric polyneuropathy, or DSPN, autonomic neuropathies, which encompass cardiovascular, gastrointestinal, urogenital, and pseudomotor dysfunction, hypoglycemia awareness, and abnormal pupillary function. The first condition that we'll go over is DSPN. All patients should be assessed for DSPN starting at diagnosis of type 2 diabetes and 5 years after the diagnosis of type 1 diabetes, and at least annually thereafter. Consider screening in patients with prediabetes who have symptoms of peripheral neuropathy. Early symptoms of DSPN include involvement of your small fibers, including burning and tingling. Your late symptoms include your large fibers, which is their numbness and loss of protective sensation, which causes a risk for foot ulcers. Assessment should include a careful history in either temperature or pinprick sensation, which is your small fiber function, and vibration sensation using a 128 Hz tuning fork, which assesses your large fiber function. All patients should have an annual 10-gram monofilament testing to assess for ulceration and amputation for the feet. Electrophysiological testing or referral to a neurologist is rarely needed for screening, except in situations where the clinical features are atypical, the diagnosis is unclear, or a different etiology is suspected. Atypical features include motor greater than sensory neuropathy, rapid onset, or asymmetrical presentation. Tight glucose control targeting near normal glycemia in patients with type 1 diabetes dramatically reduces the incidence of DSPN and is recommended for DSPN treatment prevention in type 1 diabetes. Now, in patients with type 2 diabetes with more advanced disease and multiple risk factors and comorbidities, intensive glucose control alone is modestly effective in preventing DSPN, and patient-centered goals should be targeted. Lifestyle interventions are recommended for DSPN prevention in patients with prediabetes or metabolic syndrome and type 2 diabetes. Now, specifically to treat neuropathic pain, no compelling evidence exists in support of glycemic control or lifestyle management as therapies for neuropathic pain in prediabetes or diabetes, which leaves only pharmaceutical interventions. Pregabalin, which is a calcium channel alpha-2 subunit ligand, is an effective treatment for neuropathic pain. It is extensively studied, with the majority of studies being positive regarding the proportion of responders with at least a 30 to 50% improvement in pain. There is also some evidence suggesting a dose response, with a weaker effect of 300 milligrams versus 600 milligrams a day. Pregabalin has a linear dose-proportional absorption in the therapeutic dose range of 150 to 600 milligrams per day. In addition, pregabalin has a more rapid onset of action and more limited dosage range that requires minimal titration. Adverse effects may be more severe in older patients and can be attenuated by lower starting doses and more gradual titration. Gabapentin, like pregabalin, also binds the calcium channel alpha-2D subunit. Given its pharmacokinetic profile, gabapentin requires gradual titration, and doses up to 1,800 to 3,600 milligrams are generally needed to be clinically effective. Adverse effects may be more severe in older patients with gabapentin. The starting dose for pregabalin is 25 to 75 milligrams 1 to 3 times a day, and the starting dose for gabapentin is 100 to 300 milligrams 1 to 3 times per day. Some common side effects for both pregabalin and gabapentin includes tiredness, dizziness, peripheral edema, headache, fatigue, and ataxia, as well as weight gain. Some major adverse effects of pregabalin include angioedema and hepatotoxicity, and gabapentin can cause Stevens-Johnson syndrome. For both pregabalin and gabapentin, it is important to slowly downward titrate the medication upon discontinuation to avoid seizures. Both agents can cause suicidal thoughts and behaviors. Both venlafaxine and duloxetine inhibit the reuptake of serotonin and norepinephrine without the muscarinic, histaminic, and adrenergic side effects that accompany the use of tricyclic agents, which we will talk about in a few slides. However, the level of evidence for pain reduction associated with DSPN is higher with duloxetine. Venlafaxine may lower the seizure threshold, and gradual tapering is recommended to avoid the emergence of adverse effects upon discontinuation, similar to the gabapentin and pregabalin. Duloxetine has an initial dose of 20 to 30 milligrams per day with an effective dose of 60 to 120 milligrams. Some common side effects again are nausea, dizziness, constipation, dyspepsia, and dry mouth. For venlafaxine, the starting dose is 37.5 milligrams per day with an effective dose of 75 to 225 milligrams. Common side effects include nausea, dizziness, constipation, dyspepsia, and diarrhea. Major adverse events for both of these drugs include Stevens-Johnson syndrome, hepatotoxicity, hypertensive crisis, gastrointestinal hemorrhage, delirium, and cardiac arrhythmias. They both have suicidal thoughts and behaviors as a major side effect. The monoamine reuptake inhibitors, tricyclic antidepressants, selective serotonin reuptake inhibitors, and norepinephrine and serotonin reuptake inhibitors increase synaptic monoamine levels and directly influence the activity of descending neurons. Amitriptyline, although not FDA approved, is the most used of the TCA agents. The secondary amines, nortriptyline and despyramine, have a less troublesome side effect profile than the tertiary amines such as amitriptyline, although fewer randomized controlled trials were performed with these agents. The use of these agents is preferable, particularly in older and side effect-prone patients. Several studies have suggested that there is an increased risk of myocardial ischemia associated with TCAs. Because of concerns of possible cardiotoxicity, TCA should be used with caution in patients with known or suspected cardiac disease. Despite the demonstrated effectiveness of opioids in the treatment of neuropathic pain, there is a high risk of addiction, abuse, sedation, and other complications and psychosocial issues even with short-term use. For these reasons, opioids are not recommended in treatment. The starting dose for amitriptyline is 10 to 25 milligrams per day, and the effective dose is 25 to 100 milligrams per day. Note, amitriptyline and the TCAs have a lot more side effects than the previous agents, including orthostatic hypotension, nausea, urinary retention, constipation, and blurred vision, as well as weight gain. Some major adverse events include delirium, the cardiac abnormalities that we discussed, stroke, seizures, hepatotoxicity, and bone marrow suppression, as well as suicidal thoughts and behavior. A clinician should consider either pregabalin or duloxetine as the initial approach in the symptomatic treatment for neuropathic pain and diabetes. Gabapentin may also be used as an effective initial approach, taking into account patients' socioeconomic status, comorbidities, and potential drug interactions. The tricyclic antidepressants are also an effective therapy, but one should consider the side effects that they cause. If the initial agent has no clinically meaningful effect, you can try combining the agents from above. You can switch to another agent, or you may add tramadol if A and B fail. If the patient still does not have a clinically meaningful effect, or if the therapy is not tolerated, referral to a pain clinic should be placed. Autonomic neuropathies affect the autonomic neurons, including the parasympathetic, sympathetic, or both nervous systems, and are associated with a variety of site-specific symptoms. The symptoms and signs of autonomic dysfunction should be elicited carefully during the medical history and physical examination. Major clinical manifestations of diabetic autonomic neuropathy include hypoglycemia unawareness, resting tachycardia, orthostatic hypotension, gastroparesis, constipation, diarrhea, fecal incontinence, erectile dysfunction, neurogenic bladder, and pseudomotor dysfunction with either increased or decreased sweating. Cardiovascular autonomic neuropathy, or CAN, is the most studied and clinically relevant of the diabetic autonomic neuropathies. Symptoms and signs of autonomic neuropathy should be assessed in patients with microvascular and neuropathic complications. Symptoms of CAN include lightheadedness, weakness, palpitations, faintness, and syncope. Consider assessing symptoms and signs of cardiovascular autonomic neuropathy in patients with hypoglycemia unawareness. Early stages of CAN can be asymptomatic, with the only way of detection is a decreased heart rate with deep breathing. Late stages, patients will have resting tachycardia greater than 100 beats per minute and orthostatic hypotension. Testing can be done in the office by either taking an electrocardiogram recording as the patient begins to rise from a seated position, or taking an electrocardiogram recording during 1 to 2 minutes of deep breathing with calculation of HRV. Treatment of CAN includes optimizing blood glucose and lifestyle modifications, as well as alleviating symptoms. Treatment of orthostatic hypotension can be very challenging, and the treatment goal is to minimize symptoms rather than to restore normal tension. Non-pharmacological methods include ensuring adequate salt intake, avoiding medications that aggravate hypertension, or using compressive garments over the legs and abdomen, as well as physical activity and exercise. Midodrine, a peripheral selective direct alpha-1 agonist, is an FDA-approved drug for the treatment of orthostatic hypotension. Midodrine should be titrated gradually to efficacy. It should only be used when patients intend to be upright or seated to minimize supine hypertension. Recently, droxidopa was approved by the FDA for treatment of neurogenic orthostatic hypertension, but not specifically for patients with orthostatic hypotension due to diabetes. Gastrointestinal neuropathies can affect any portion of the GI tract and can cause esophageal dysmotility, constipation, diarrhea, fecal incontinence, and gastroparesis. Markedly uncontrolled glucose levels greater than 200 mg per deciliter may aggravate symptoms of gastroparesis and delay gastric emptying. Gastroparesis can be associated with and may aggravate gastroesophageal reflux disease, or GERD. Evaluation for presence of gastroparesis should be considered in patients with GERD that is refractory to acid suppressive treatment. Documented delay in gastric emptying is required for the diagnosis of gastroparesis. Scintigraphic gastric emptying of solids is the standard for the evaluation of gastric emptying and the diagnosis of gastroparesis. The most reliable method and parameter for diagnosis is gastric retention of solids at 4 hours. Medications that affect gastric emptying should be stopped at least 48 hours before diagnostic testing, particularly narcotics, anticholinergics, GLP-1s, and amylin analogs. Now, depending on the pharmacokinetics of the medication, the drug may need to be stopped greater than 48 hours before testing. The presence of eating disorders, including anorexia and bulimia, and cyclic vomiting syndrome, defined as recurrent episodic episodes of nausea and vomiting, should be considered when evaluating a patient, as these disorders may be associated with delayed gastric emptying and may alter management. Chronic usage of cannabinoid agents may cause a syndrome similar to cyclic vomiting syndrome. Patients presenting with symptoms of gastroparesis should be advised to stop using these agents. The first line of management for gastroparesis should include restoration of fluids and electrolytes, nutritional support, and optimizing glycemic control. Oral intake is preferable for nutrition and hydration. Patients should receive counseling from a dietitian regarding consumption of frequent small volume nutrient meals that are low in fat and soluble fiber. If unable to tolerate solid food, then use of a liquid nutrient meal is recommended. Indications for enteral nutrition include unintentional weight loss of 10% or more of the usual body weight during a period of 3 to 6 months, and or repeated hospitalizations for refractory symptoms. When treating gastroparesis, offending medications should be stopped, including opioids, anticholinergics, TCAs, GLP-1s, DPP-4s, and pramlintide. Metoclopramide is a dopamine D2 receptor antagonist and is the first line for prokinetic therapy. It should be administered at the lowest effective dose for each patient and liquid formulation is preferred to improve absorption. Given the risk for serious adverse effects, including extrapyramidal signs such as acute dystonic reactions, drug-induced Parkinsonism, and tardive dyskinesia, its use in the treatment of gastroparesis beyond 5 days is no longer recommended by the FDA. It should be reserved for severe cases that are unresponsive to other therapies. Erythromycin can improve gastric emptying and symptoms from delayed gastric emptying. However, the long-term effectiveness of oral therapy is limited by tachyphylaxis due to down-regulation of the motilin receptor. Clinical responsiveness drops after 4 weeks of oral erythromycin therapy. However, some patients may continue to experience benefit. Treatment with antiemetic agents with the antihistamine 1 receptor and the 5-HT3 antagonist should occur for improvement of associated nausea and vomiting, but will not result in improved gastric emptying. TCAs can be considered for refractory nausea and vomiting in gastroparesis, but again will not result in improved gastric emptying and may potentially retard gastric emptying. Other therapy includes gastric electrical stimulation, surgery, and acupuncture. Erectile dysfunction is 3 times more common in men with diabetes than those without the disease. Sexual dysfunction is also more common in women with diabetes. ED may be a consequence of autonomic neuropathy, as autonomic neurotransmission controls the cavernosal and detrusor smooth muscle tone and function. The etiology, however, is multifactorial, and clinicians should also evaluate other vascular risk factors such as hypertension, hyperlipidemia, obesity, endothelial dysfunction, smoking, CVD, medication, and psychogenic factors. Consider screening men with other forms of diabetic neuropathy annually for ED with simple questions about a patient's libido and ability to reach and maintain an erection. The treatments will not change the underlying pathology and natural history of the disease process, but can improve the patient's quality of life and include the PDE5 inhibitors, such as Viagra, the intracorporeal or intraurethral prostaglandins, and vacuum devices or penile prosthesis. Pseudomotor dysfunction may manifest as dry skin or heat intolerance. A rare form of pseudomotor dysfunction is gustatory sweating that is triggered by food consumption or in some cases the smell of food. Gustatory sweating is also described in patients with diabetic neuropathy on dialysis. The treatment of choice is a topical antimuscarinic such as glycopyrrolate. For all patients with neuropathy, other diseases or causes should be considered, such as metabolic disease, as thyroid or renal disease, systemic disease, infectious such as HIV, hepatitis B, or Lyme disease, inflammatory processes, nutritional deficiencies such as vitamin B12 or thiamine, drugs including alcohol, amiodarone, colchicine, and your chemotherapy agents, and hereditary causes. All patients with diabetes should have a comprehensive foot evaluation at least yearly and a foot inspection at every visit. In certain patients who are above 50 years and in any patients with symptoms of claudation or decreased and/or absent pedal pulses should be referred for further vascular assessment. Specialized therapeutic footwear is recommended and preventative foot self-care education for all patients with diabetes. Due to the high risk of complications in patients with diabetes, patients should undergo vaccination screenings. All patients with diabetes greater than 6 months of age should receive the influenza vaccine. In a case control study, the influenza vaccine was found to reduce diabetes-related hospital admissions by as much as 79% during flu epidemics. Also, people with diabetes have been reported to have a high risk of nosocomial bacteremia with a mortality rate as high as 50%. Due to this, patients with diabetes aged 2 to 64 years old should receive a PPSV23 pneumonia vaccine. Patients greater than 65 years should receive a PCV13 pneumonia at least 1 year after the PPSV23, followed by another PPSV23 at least 1 year after the PCV13 and at least 5 years after the PPSV23. Compared to the general population, people with type 1 or type 2 diabetes have higher rates of hepatitis B. This may be due to the contact with infected blood or through improper equipment use, such as your glucose monitoring devices or infective needles. In adults with diabetes aged 19 to 59 years, a 3-dose series should be administered of hepatitis B to your unvaccinated adults. You can consider the hepatitis B vaccine as well in patients greater than 60 years.